Hello, everyone, and thank you for joining today's I3h reading seminar, which is the last seminar of the semester. Our speaker today is Mario Fontán Vela of the Ministry of Health in Spain, who will teach us about health technologies assessment. If you'd like to ask a question or make a comment, you can use the Q&A section in the Zoom, and we can also promote you to a panelist to ask your question live. But we'd just like you to keep your questions until the end of the presentation. Thank you very much, and here is Mario.
Thank you very much. Thank you for the invitation to join in this seminar. It's a pleasure for me to explain a little bit about health technology assessment and also give you some insights on how are we dealing with this issue currently at the Ministry of Health. Just a brief explanation of myself. I'm Mario Fontán Vela. I'm a medical doctor. I have a PhD in epidemiology and public health at the University of Alcalá. Mostly, I had my research career in urban health, social inequities, and vaccines products. I'm a social epidemiologist. I'm not a pharmaceutical expert, so sorry if I make some mistakes during the presentation because it's not my research field, the health technologies. But since December of 2023, I'm an advisor to the Secretary of State at the Ministry of Health of Spain, and I'm working with the people of the pharmacy area of the ministry that is working currently in developing a new health technology assessment system in Spain. So I'm familiarized with the issue and the matter, but I'm not quite the expert of the person with the most expertise at the Ministry of Health. So I will give you some insights, some key elements of about this issue and how are we dealing with it in Spain. But just to clarify that I'm a social epidemiologist. So this is the agenda of the seminar. Why we need to talk about this issue, the health technology assessment. What is the health technology assessment? Some advantages that this method, that this interdisciplinary methodology give us as a government, but also as physician or health professionals, and which are the limits also of this methodology, which is the context of health technology assessment at the EU level, because I think it's interesting to know how this macro level condition the countries about the regulation. How are we dealing with health technology assessment and how we are developing our new system in the Spanish context. Some future challenges to talk about and some brief conclusions about the whole seminar. So why we need to talk about health technology assessment? Since 2015, the health expenditure per capita across the European Union has grown around 3.4% on average. Currently is around 3,500 euros in 2022. And this health expenditure not only has grown in the last year, but it's continuously growing since, I think we can almost say since the beginning of the national health system, but mostly since the 2008 economic crisis. There is some variation both in the health expenditure per capita across the countries and also in the growth rate, but we can see that the general trend is that this health expenditure is growing and growing, apparently without limit. Here in this figure, you can see the average annual growth rate, 3.5 for the European Union, but there is some countries like Cyprus, Malta, who are facing a bigger growing rate. So it's a really important issue in terms of sustainability of the national health system, and we have to look the main reasons that explain this growth in health expenditure across countries. As I said before, this growth rate apparently has no limit, but as politicians, as the people who have to make the decisions about how is financing the national health system, to which areas we dedicate our health expenditure, we think to be realized that healthcare systems cannot grow without limit as the country, as the planet, sorry. what are the main factors that explain the increase or the variances in health expenditures? There are a lot of factors, some differences. No, it depends on the demographic characteristic of the populations, also in social and political norms. It depends also if the population support a bigger health expenditure for the national health system, or support in political or ideological terms a cut expenditure in the public health expenditure. Also, it is related to the economic system and the economic structure of a country, how we decide the options to finance, how we organize our national health systems. Alongside with the demographic characteristic of the population, also is how is the health status of the population, and how are affecting the social determinants of health to the health status of the population, how the inequities in social terms affect the health outcomes of a population. Here is a classic diagram to explain how national health services are financed and how we should think about the universal coverage of the national health system. So to summarize, if we think about the national health system finance, it depends mostly in these areas. How many of the population is covered by the national health system, the amount of services that are covered by the national health systems, and also the proportion of the cost of this service that are covered by the national health systems. If we modify some of these factors, if we have a mostly or a universal coverage of the population by the national health system, the health expenditure will grow. But if we increase the number of services, this health expenditure will grow also. And also, if these services are has a higher cost, also the national health expenditure will grow. And how these factors are modified or vary during across the time, so will the national health expenditure vary. If we think about the population covered by the national health system, we have to realize that in the last decades, the life expectancy of the population has grown worldwide, but especially across the European Union. Currently, the life expectancy in the European Union is around 81 years. In Spain, is 84 years. And we have to think that these years, the 75% are healthy life years without any disease, but the 25% of these years, this life expectancy, are experiencing with some activity limitations due to some chronic disease, some problem related to the mobility, to the capacity of the people to make their daily activities. So we have to think that an important part of this is the life of the individuals in our region. An important one is with some burden of disease, some disease that is affecting their capability to work, the capability to conducting their regular activities during the days. And this burden of disease increase the cost of the national health system, affect also the labor workforce and how the economic system, the outcome of the economic system. So it's a burden that we need to think about when we organize and we think about the national health expenditure. So as I have said, since 2000, we can, of course, in 2020, we have seen a decrease in life expectancy due to the COVID pandemic, but the general trend that you can see in both figures, the figure of the left is the life expectancy at birth, and the figure of the right is the life expectancy at age 65. You can see that this life expectancy has increased since 2000, and we are seeing gains in life expectancy, slightly gains, but they are important and put some pressure in terms of burden of disease of our population. Since 2005, we live a little bit longer and slightly healthier. As you can see, the life expectancy has increased in 1.2 years, and almost the 66% of this increase came from a healthier life gains. So this is a good good result, that we live a little bit healthier compared to 2005. But in general terms, remember that 25% of the life expectancy is with some chronic disease. And which are the projections in terms of demographic changes or in terms of the burden of disease of across the population? By 2050, it is expected that the share of population above 65 years will increase. Currently is around across the European Union around the 20%, but it's expected that it will increase to the 30% of the population will have more than 65 years. And now, at this moment, currently, 2023, 60% of the people aged over 65 across the EU has at least one chronic disease. But more than 40% of the subgroup of the population report having at least two chronic diseases. So we have to keep in mind this prevalence of diseases across the population, especially across the elderly group, to think about how is the pressure in expenditure terms in our national health systems. The more prevalent chronic diseases that are causing these years of life with disability, remember there is around 25% of the life expectancy. The more prevalent are dementias, diabetes, cardiovascular diseases, and cancer. So diseases that for which we don't have already a treatment. For some cancers, we have some treatment, no? But in general terms, these are chronic diseases that will last all the rest of the life of the population. And this will keep increasing the pressure to the national health system in terms of work pressure or pressure in terms to how we organize this national health system to take care of an elderly population and a population with more diseases, but also in economic terms. And I repeat this word, economic terms, because it's important when we talk about health technology assessment. So some risk factors that increase the burden of disease among the older individuals are the classic ones, no? The level of physical inactivity, the malnutrition, the overweight, air pollution and street temperatures, and lifestyle choices like smoking or drinking alcohol on the regular one. So when we talk about health policies, we have to think about how we design these policies to decrease this risk factor, because the higher the levels of this risk factor are in a country, higher prevalence of chronic disease, so higher pressure on the national health system. This was the part related to the characteristics and the proportion of the population covered by the national health system. But as I said before, we have to think also about the services that we provide to the population and the cost of the services that are covered, and so the individuals don't pay for it when they go to the national health systems. So as I said, a population with a higher prevalence of chronic diseases needs a higher pharmaceutical expenditure. As you can see in the figure of this slide, the increase, the annual average growth in retail and hospital and other non-retail pharmaceutical expenditure has increased in the last decade. For example, for Germany, in hospital and other non-retail pharmaceuticals, more than 10%. In Spain, is 8%. So it has been continuously growing. So we think about how we can deal with this growth rate in terms of the expenditure dedicated to pharmaceuticals products. But also because the pharmaceutical industry has become more important especially since the pandemic, the pharmaceutical industry has become more important in strategic terms. It's an important sector of the economy in terms of innovation, employment, contribution to the economy of the country, but also in terms of the benefits or the health outcomes of the population. It has a global contribution to the world GDP around almost $2 billion. It's the same GDP as the whole country of Netherlands, for example, to contextualize how important is this sector in economical terms. The use of medicine is expected to grow 2% annually over the next 5 years. and the global medicine market is expected to grow at a rate of around between 5 and 8% through 2028, reaching about $2.3 trillion in total market size. So it is important in strategic terms, it is important in terms of the impact to the economy, in the impact to the health of the population, but also we have to think about how we deal with this increase in the economic size of the pharmaceutical industry, because it can put at risk the sustainability of the national health systems. And to conclude, the main therapy area driver of this growth in medicine are immunology, endocrinology, and the oncology sector. As I was saying, the pharmaceutical sector has experienced also an increase of the number of molecules entering into the market, but also an increase of the cost to produce a new development. So new medicines, new molecules, new products are becoming more present in the last years, but also they have higher cost. So how we choose which of this molecule should be incorporated to the services provided by the national health systems, how we choose between different options, it's an issue that we should deal with as countries, to guarantee to the population the sustainability of our national health system. We cannot grow the national health expenditure without limits and incorporate every molecule that enter into the market. So how we decide which molecules are worth to increase the coverage of these molecules by the national health system, and how amount of this cost is worth it. So, as I was saying during this part of the presentation, some questions arise during seeing these numbers and the statistics and how the population have changed and how the pharmaceutical industry have changed during the last years. How we define a benefit in terms of health outcome should be gains in life expectancy, should be gains in quality of life, should be measured as number of strokes avoided by this new technology. It is difficult to decide, and only one indicator. It should be a variety of indicators for sure, but how we define this benefit in terms of health and benefit to the population. Should all new drugs or health devices be covered by the national health systems? How we define a new molecule or a new health technology as innovative? Is this innovation worth to be covered by the national health system? Should governments be willing to pay any price for a new drug or a new device? And how we decide which price is fair for a new drug or health device? These are important questions. These are difficult ones. It's a very complex process, but health technology assessment is like a methodology that help us to answer some of these questions. Maybe not all the questions, but the most important ones for sure. So to summarize the information that I gave to you, as this moment, life expectancy has increased during the last 2 decades. The burden of disease and economic burden to the national health system are expected to grow in the next decades. The number of new pharmaceutical products is higher, but also the cost of research and development that are translated to the final product. And governments are facing more complex decisions relating to the incorporation of innovation into their national health systems. So how governments should deal with this apparent limitless growth in health expenditure with using or supporting in health technology assessment. What's health technology assessment? This is like the academic definition of health technology assessment. Health technology could be defined as any intervention developed with the aim of preventing, diagnosing, or treating diseases or medical conditions, and that promote health, rehabilitation, or organization the delivery of healthcare services. This intervention may include diagnostic tests, medical devices, drugs, vaccines, clinical procedures, programs, or healthcare delivery system. As you can see, almost everything that is put into the national health system could be a health technology. So this methodology of health technology assessment can cover all these type of products or devices or organizational ways to deliver the healthcare to the population. Classically, to every health technology, obviously, mostly for new drugs or new devices, there is a clinical evaluation to measure the efficacy of this product, so the benefit that can be achieved with this health technology within certain controlled conditions. I don't know if you are familiar with the term clinical trial, but the clinical trial conduct this type of clinical evaluation. If the drug has some efficacy in health benefits, also if the drug is safe. When we talk about safe, we are not saying that a drug or a medical device doesn't have any risk. We are talking about the risk acceptability of a health technology. For example, we know that with some medicines or some vaccines, there are some side effects, but the benefit that gave this product are higher than the side effects that could provoke in individual and in population terms. So when we talk about safety, we talk about the risk acceptability and also the quality that is related to the description and characteristics of a health technology. But when we talk about health technology assessment, we talk about also not this clinical evaluation that is related more to the regulatory assessment or the regulatory part of the health technology assessment. There are also some non-clinical domains that we should take into account when we decide to incorporate one health technology to the national health system. There are some ethical aspects, some organizational aspects, how this health technology will be delivered by the health professionals, and if we have to change how the services in the national health systems are organized to deliver this new health technology, some social aspects and some legal aspects. But the key issue of the health technology assessment is that we incorporate the term of efficiency into this analysis. The efficiency is related to how we keep an equilibrium between the economic part and the health benefits of a technology, taking into account all the technologies that we have and that provide some benefits in health terms. For example, it's not the case of the rare diseases is very uncommon because we have diseases without a clear treatment. But if we can think about the diseases that I have explained before, dementias, cardiovascular diseases, or oncological diseases, we have a range of treatments or medicines or health devices that we can use and that we are currently using. So how we put a new technology that show up in the market, how we put it in the context of the other health technologies that we already have. So now the definition of health technology assessment will be a multidisciplinary process of comparative evaluation of the medical, social, and patient-related aspect, as well as the economic and ethical issues associated with the use of a health technology, conducted in a systematic, transparent, impartial, and rigorous manner. So we have to think about health technology assessment not within the regulatory process of a new technology. That should be this clinical evaluation that usually comes from after a clinical trial that prove that the new medicine give us some health benefits, is safe, and have some efficacy. That would be the regulatory process that present the results to the European regulatory agencies, such as the EMA, or to the Spanish one, depending on the context. But health technology assessment is not the decision about the financing and the price. So this is a process that is between the regulatory part of the process and the financing and price decision about to incorporate some new health technology into the national health systems. how health technology assessment help us to take this type of decisions. Minimizing the cost opportunity of the new health technology, put it into the context of the other alternatives that we have to treat some certain diseases. By reducing the uncertainty level inherent to innovation in health technology, you have to think that a new molecule or a new drug that haven't been used before comes with a high level of uncertainty because we have the information about the clinical trial, but clinical trials are in very controlled situations about the type of the population, about the delivery of the product that is measuring. But when we apply this new product to the whole population, and we talk not about efficacy but effectiveness, the results can change. So this uncertainty, with also, especially with new products, are very high. So health technology assessment help us reducing the uncertainty level inherent to this type of innovation. Help us also to inform decisions on financing and price of new health technology made by the political level. Also help us in terms of budgetary control by constraining the impact on the national budget of this technology. Limiting the asymmetry of the information about the health technology. Usually companies have more information than governments, national health system, health professional or patients when it comes to this new product. And also reducing this gap between efficacy and effectiveness. As I have explained before, the differences that we've seen from the result of the clinical trials to the implementation in real life conditions of health technology. Health technology assessment, as I said, help us to analyze the cost opportunity in terms of the introduction of a new health technology into our national health system and covered by the public sector. Because, as I said before, the rare diseases are an uncommon situation, but usually we are in a scenario of a variety of health technology alternatives to implement or to give some patient for certain conditions. We are in a context of limited economic resources, so we have to choose which health technology worth an increase in health expenditure, for example, for a country, because the resources are limited. Also because we are mandated to, in my case, as a public worker in the government, to make a good use of public budget and to justify why we decide to cover this new health technology, and we have to have some methodology that give us reasons to incorporate some new health technology into our systems. Also because we have to maximize the health benefit of current and future health technology for current and future patients. If we increase without limit the national health expenditure for one health technology, maybe in 5 or 10 years, we couldn't afford to pay 5 new health technologies that will help us to reduce the number of dementias or the number of strokes or the number of I don't know, diabetes. No? So we have to think about not only the current situation in health status terms, but also how this could be into the future. This situation in terms of health, situation of the population, and the amount of health technologies that we will have. Usually, when we talk about cost opportunity, some people critique that this shouldn't be an economic issue, but cost opportunity is not an economic issue to debate about. It's an ethic one, because as I have said before, the amount of resources are limited. So we have to choose very wisely into which technologies we put an increase in national health expenditure. And this is a very difficult situation. It's not a technical one, or not only a technical one, but it's also an ethical one and a political decision. And just a reminder that a higher efficiency doesn't mean cut funding. Maybe one health technology, the cost of one health technology is very high, but if this health technology really improve our health outcomes, it shouldn't be only the cost, the reason to not include this health technology into our national health systems. So usually people, when we think about cost opportunity, some people think that is only reducing costs and only incorporating those health technology that are cheap. Is not that. Analyzing cost opportunity is not cutting funding to new health technologies, but we have to choose very wisely which health technology are worth to increase our national health expenditure. So some key features of health technology assessment. First will be the scope. If this health technology assessment cover only drugs or health technology or health programs or organizational models or everyone, which type of evaluation we conduct. If we look only to the efficacy, to the effectiveness, to the safety or the efficiency of the health technology, and which efficiency indicators we choose. Could be the cost effectiveness that we use and that explain us the clinical outcomes that a new health technology provide to us, or the cost utility, and which is the gain in terms of life expectancy without a disability. So depending on the indicator, the result could be different, and also this could affect the decision about to incorporate a new health technology. Which are the objectives of the health technology assessment? Is to inform the political decision on financing and price of a new health technology. And it's important to keep in mind that this health technology assessment should be separated from the political decision. Health technology assessment is a technical or mostly technical analysis that will inform the political, the people in charge in the Ministry of Health or in the Ministry of Science, depending on the country, to if we should incorporate some health technology into our national health system. Should keep some autonomy and independence from the political level. Also, how it's organized internally, which professionals conduct this type of analysis, if this analysis incorporate people outside the healthcare sector, such as civil society or even patients. Also the transparency and the participation during the process about different stakeholders. It's important that there is some availability of resources, economic, material, or human resources to conduct this type of analysis, and the accountability to the population, in legal terms or in political terms. So health technology assessment has some advantages. Health technology assessment help us to achieve the institutionalization of decisions. Because decisions are removed from the private domain. Normally, there is not so many countries that have a lot of transparency about how they decide which health technology are incorporating. So if we are transparent during this process, all the actors, the companies, the patients, the society, the political, will know how is this decision are made. And for instance, this will give more legal security to every stakeholder that participate in this process. And decisions can be applied universally and consistently, avoiding fragmentation and inconsistencies. Also help us to formalize this decision that gives legal security, and this increases our predictability that help also the companies to develop their molecules and to which elements they should expect when they provide a new molecule to a government, to a national health system, and they ask for the incorporation to the financing and to be covered by the national health system. And also, it's important that these rules, procedure, and methods are published and transparent. Also, help us to professionalize and incorporate technical expertise to this process. This methodology should be based on science, professional knowledge, and experience in health technology assessment. And they should incorporate also external expert advice, especially from the healthcare system, that can be utilized in certain conditions. Also enable economies of scale and reduce the cost of this type of evaluation. If we have a centralized agency or centralized department that conduct this type of analysis, it will help us to reduce the cost and not having a lot of actors conducting this type of analysis. increase the quality of the decisions made about the incorporation of a health technology, and can provide a solid basis for collective decision, not only in terms of macro level and how we organize the national health system, but also how to incorporate and use this new technology into the system. So this kind of analysis help also the professionals in their activities. But there are some limitations in order to implement the health technology assessment in the daily basis of the administration. There are some administrative barriers. So the amount of resources to conduct that a government has are limited. So we have to struggle about to convince that this system should be applied into the future, and that will help us to reduce some costs and to make better decisions. So there is some political negotiation within the government to convince that this system should be applied. And also, if we don't have a legal obligation to conduct this type of analysis in our legal framework, so it's like this is not an important thing to implement. No? There are no incentive to implement this type of analysis. There are some methodological barriers because this type of analysis are difficult to understand by clinicians and by the politicians, and the savings that this type of analysis show or provide is in a theoretical way. It's not like if we implement this health technology, you will save this amount of health expenditure in terms of better health outcomes within the population, because this is like a theoretical exercise, is a projection, but we are not sure certainly how much will be the savings in 5, 10, or 15 years. So it's difficult to convince with this argument, because it's not an amount of expenditure that you can show actually, because it's projected in the future. And there is some variability in healthcare costs between regions, within a country, between different health systems within a country, because in Spain we have a decentralized country. So this incorporates some level of complexity, and also some implementation and practical barriers related to the influence of the industry and the lack of economy evaluation studies dealing with the common problems in daily clinical practice. In the EU context, we have recently in 2021 a regulation that incorporates the health technology assessment in the European Union. It is important to remark that there is no economic assessment or any conclusion on pricing and reimbursement with this regulation. This regulation is only related to the clinical part of the clinical assessment of the evaluation. The scope is not only drugs, but also medical devices. So at the EU level will be starting in June 2020, in January, if there is a mistake. In January 2025, we'll start this process. And in the following years, will be incorporated for every drug and every medical device. It will start with the oncological one, if I'm not mistaken. But it only includes this clinical assessment. The technology, the economic part, of the social part, of the ethical part of this assessment will be conducted by the national governments. But this will help us to accelerate and to make the process quicker in terms of predictability and in terms of incorporation these new technologies into our national health systems. It creates a governance structure to conduct this clinical assessment, a group to consultate about scientific issues, also a group that will identify emerging health technologies to reduce the waiting time to incorporate this new technology, and a group that will develop the methodology framework to conduct this health technology assessment. And this governance structure have representatives from all the countries, but also will have some relationship with other stakeholders related to health technology, such as professionals, such as the industry, such as patients, group of patients, and so on. So the aim of this regulation is to improve the availability of innovative health technology within the EU, ensuring the efficient use of resources and enhance the quality of health technology assessment across the Union, reducing the duplication efforts for national health technology assessment authorities and the industry, and providing a transparent and inclusive framework by establishing a coordination group of national and regional health technology assessment authorities, a network of stakeholders, and rules of participation in joint clinical assessment and joint scientific consultation. So it's a very solid regulation to improve not only the health technology assessment across at the EU level, but also help us at national level to be quicker in terms of detecting some health technology emergencies that could be interesting to incorporate to help in the development of this new health technology, and to facilitate us this health technology assessment at a national level. In the Spanish context, I will give you some information in case you don't know how Spain is organized at political and especially in the national health system. We have a population around 48 million of individuals. Our national health system budget is around 100,000 million of euros, around 7.4% of the GDP. The expenditure on health technology is around 22,000 million euro in 2023, with a growth rate of 5.1% compared to the previous year. And we live in a decentralized country, so the autonomous regions in Spain are in charge of providing the health services, and the central government has the role of coordinate and to keep the cohesion of the national health system. In terms of our health technology assessment legal framework, the central government has the right to conduct health technology assessment to incorporate new health technology into the common portfolio of health services that every region should provide to the population. But the autonomous regions could complement this health technology assessment of the common portfolio in order to regulate the access to the services included in the common portfolio, to restrict some services to certain subgroups of the population where the effectiveness are higher, for example. Or the autonomous regions can also conduct their health technology assessment in order to incorporate different services to the complementary portfolio of health services. So we have a common portfolio that all regions should provide to the population, but it can change with the amount of population covered by these services. And also the autonomous regions can incorporate a complementary portfolio of these services. And in that case, they can conduct also this health technology assessment. We have two national structures for conducting this health technology evaluation. We have the I3h, in Spanish is the Spanish Agency of Medicines and Medical Devices. And we have a national network also to evaluate health technologies, more dedicated to medical services and not to drugs. But the economic evaluation is not systematic at this moment. It has improved since 2019, but it's not systematic at this moment. And there is some room for improvement to have a more cohesive and organized structure of health technology assessment. So now, this is the important thing. Currently at the ministry, we are working on a new legislation to create the Spanish health technology assessment system that will be approved, hopefully, by the beginning of 2025, and that this new regulation will be aligned with the European one. So it complements and incorporates some of the issues that currently are regulated at the European level. So this is the governance structure that we have designed. We will have a governance council, and we will have two offices to conduct this evaluation of deficiency. The office for drugs, that will be led by the Spanish Agency for Drugs and Medical Products, and an office also for medical devices, more the part of the more technological part of these devices, that will be led by this Spanish network of agency of health technology evaluation that we currently have, but we think with this regulation, this system will be more cohesive and more coherent, and we will improve the interlocution between these two offices and two systems. And these offices will conduct this health technology evaluation that later will incorporate the economic part. And we will have also two positioning groups that will decide, will recommend or not to incorporate some new health technology. But the decision on the incorporation, or also the financing decision to incorporate this health technology into the national health system, and which is the price for this health technology, is a political decision in the structure of the Spanish government. This governance council will have representatives of the Ministry of Health, the offices of the Health Technology Assessment System, the autonomous regions also, but also healthcare professionals, health economists, patient organizations, consumer organizations, and also representatives of the central administration from other ministries, not the health one. These offices, as I have said before, these offices for the evaluation of efficiency of new drugs or new devices will elaborate the clinical and economic evaluation. They will detect emerging health technology and will decide the methods and the timeline of the evaluation process. The positioning group, with information made by the offices, will elaborate a final report that will inform the decision made by the political level about the financing and the price of a new drug or a new medical device. More key elements of the Spanish health technology assessment system, we will separate the clinical and economic evaluation. And the economic evaluation, which will approach the budgetary impact, the potential impact in budgetary terms of the incorporation of a new health technology. And this evaluation will not decide about financing or price. This is an important issue when we talk about health technology assessment. It's important to separate this technical evaluation from the political decision about incorporate and decide a price for a new health technology. The methods that guide evaluations will be public, and the evaluation and the positioning report will be published without the confidential information that could affect some industrial information, for example. This system, as I have said, will detect new health technologies that could be incorporated into the market in the future, as the health technology assessment system at European level will do also. The system will cooperate at national and international level with other institutions, and the companies should publish the financing sources of their health technology, if they are public or private. The waiting times of the different steps of the health technology assessment will be public to increase our legal security and information and the predictability of our system. Patient, consumer, and professionals should be encouraged to participate and taking into account the potential conflict of interest of this professional, but also for everyone in the system. And the system, we have assured that the system will have sufficient budget to carry out all these functions, because we need, as I have said before, we need not only human resources or material work, but economic, because this type of evaluation has costs. Sorry. Some future challenges that we will face in the right future: the economical situation at national and international level. If there is some constraints in the budgetary of the government as a whole, this could affect the budgetary dedicated to this type of system or to health expenditure in medical products. The development of advanced therapies and the personalized medicine, we are seeing that the new molecules are more personalized and dedicated to some and focus on some certain diseases, and within the diseases, some characteristics of a subgroup of population of this type of patient. So this will increase the cost to incorporate some health technology, and we have to face and we have to deal with these changes in how drugs are developed, and also because we are seeing more complex medicines that do not fit in the traditional definition of health technology. For example, a new drug that need a genetic test before to be implemented to see if the characteristic of the patient fits the characteristic of the drugs, so the drug could be effective. So the traditional definition of health technology is that doesn't fit how new products are implemented at this moment. We will we will have to deal with the population and the increase in life expectancy and the potential increase in burden of disease of our population, and how this will increase the cost of that governments face about health products. Also, the sustainability of national health systems and how this aging and how this increasing the cost of development and research of new products put some pressure in our national health systems. Also, we will have to face some social or political changes in the preference of the population in terms of public budget, for example. And also an interesting thing that we are now debating at the EU level, but also at national level and internationally, how we measure the environmental impact of health technology. Always putting the safety and the health of the population at first, but how we take into account the environmental impact of these technologies and how we measure it and how we incorporate this information into the decisions about financing or about the deciding a price of this new technology. So some conclusion of this seminar: the epidemiological transition, the aging of the population, and the increase in the costs of health technology production was at risk the sustainability of the national health systems and the health expenditure of the government. Health technology assessment is an important tool to reduce the uncertainty of innovation in health technologies that could help us to make decisions on financing and price of new health technologies. Health technology assessment should distinguish between the technical evaluation and the political decision, and this system should be autonomous, participative, and transparent. Governments should improve how they evaluate new health technologies and coordinate at international level to share experiences and optimize efforts. And health technology assessment should be seen as an important tool also for companies that could help the research and innovation process and benefit the pharmaceutical sector, giving them more legal security and more predictability from the government, so they can decide with more information about their research and development process. So thank you very much. Sorry for my nerves and my English, but I hope that you have understand how health technology assessment works and why they are important to decisions at the political level. Thank you very much.
Do we have any questions? Michel?
Yes, first of all, congratulations. I think that's really a very interesting seminar which puts HTA in perspective. I would like perhaps to start by coming back to the definition of HTA at the beginning of your talk. When you look at this definition, actually, it should apply to everyone in the world, right?
Mm-hmm.
Which,
yes. I'm trying to share the presentation to see one moment. And one moment. Sorry. Yes. Can you see the slide of the definition?
Yes. I saw that there was also another slide, but anyway, that's the point I would like to make is that there's been clearly an interesting European approach with UNETA. Now you mentioned that there will be a regulation. No, I would say that you mentioned at different moment of your seminar, pharma companies. Obviously, pharma are driven by their own rules, and pharma are global throughout the world, and they can play with this, of course. And you didn't mention the US, but as you know, the US for most pharmas are the dominant market and have a strong influence on the prices, which are also used in Europe. So I was just willing to ask you, how you see indeed the consideration of pharma priorities in HTA.
Yeah, I think that not about health technology assessment, but related to the the pharma ecosystem in Spain, for example, we are developing, and I hope that we can present this in the future months. We are preparing also a national pharma strategy. And I think that one important thing about this strategy is how we move from a current market that is more oriented to the interests of the farmers and how they. I mean, I think that now the pharma market depend mostly in which product the pharma can offer to the governments and to the national health systems, and the market is not based on the needs of the population in health terms. So maybe we have a high amount of new molecules in the last decades. We have seen that, but how these new molecules are aligned with the actual needs of in terms of health of the population. So I think that this Spanish strategy for the pharmaceutical industry will try to send signals to the pharmacies, to the pharma companies, to develop molecules in that we are interested as a government, because we have needs in terms of rare disease, in terms of chronic diseases, in terms of antibiotic resistance, for example. So this is one thing. Obviously, pharmaceutical industries are driven by economic results or economic interest, because they are private companies, that's for sure. But we think that with this health technology assessment system that we are incorporating in Spain, and we will develop it in the future years, we hope that we could keep a balance between this economical interest and the social need of the population within this health technology assessment process. We have to incorporate to this system professionals without conflict of interest, that for sure. But we think that pharmaceutical companies will say to the government, obviously, that this new product is perfect and is the best product in the world, and will help us to decrease the prevalence of some chronic disease, and this product should be delivered during the following decades to all the population. But we think that this health technology assessment could help us to deal with some of this information that could be real, and this new product could be amazing in terms of health outcomes, but to put this new product in the context of the alternatives that we have, and to balance also with the situation of the health status of our population, the national health expenditure, how we have the national health system organized, if we can deliver correctly this new product or not. So obviously this interest of the companies could influence, but with this system, I think we could manage this interest in terms of having a comprehensive analysis of this new product to make a political decision about their incorporation to the national health system or not, and also the price. And just a last comment on that. I think that we have to work at international level in terms of transparency about the price of drugs, because currently it's an information that is not fully shared and fully publicly available, even at country level and the cooperation between countries. So I think our next step will be to work this at the EU level. That is our political context. But I think we have to move to a more transparent system about the prices of drugs at international level, and to know how we are paying, how much of money we are paying for different drugs. I think that contrary to the popular opinion that this will have a bad impact on countries with worse economies, I think that will improve at international level the access to some drugs, and to decrease the amount of money that we pay for them.
Thank you. Just one comment, and then I will give the word to Matthias. I think that what's quite important, and you emphasize this, is the prevention, because, you know, prevention, you don't need drugs, and you might have
Exactly.
a huge effect. And I think that now with these new anti-obesity drugs, Wegovy, you have a good example, and there will be probably difficult decisions to be made, and that should be indeed coordinated at the largest level internationally. And it's about prevention. It's also about ethics. I think that the ethics should not be so different from one country to the other. So really, this coordination is very important. Also to avoid, you know, that people, the parallel import of medicines, and the fact that people travel to get the drug in a country where probably the the access is easier. So clearly, international collaboration is important. Now, I'm sure that Matthias would like to comment on the final outcome of HTA by the politician, which is indeed the price of the drugs that we can accommodate. And the question is whether, together with what you mentioned, that is organized at the European level, we should not go more to combined or pre-orders and indeed the joint procurement for drugs, especially drugs which are quite expensive.
I don't know if Matthias will want to. Yeah.
Okay. Well, thank you very much for a very interesting and informative presentation. My question, I mean, you explained well how, you know, the chain of steps for a drug to be distributed. So you have the indeed the authorization, FDA in the US, EMA in Europe. Then you have health technology assessment that's focusing on efficiency as opposed to just efficacy, safety, and so on. And then you have pricing and reimbursement and all that. Now, in Europe, you have the EMA and the EU level. And then afterwards, you have a lot more kind of less coordination, even though you explain how health technology assessments are trying to coordinate across the EU. Now, in the Draghi report, Mario Draghi, on the future of EU competitiveness, well, it is said there that okay, in the pharma sector in particular, we are much stronger relative to the US than, let's say, in the big tech sector, where we are, as I say, you know, a bit pathetic in compared to the US. On the other hand, the Draghi report says, look, we are not doing very well in the growing markets, sub-markets. I think that it says that between 2012 and 2022, the global sales budget, total level of sales at world level for drugs was plus 50%, 50, but for biological plus 150, so 3 times more. And the orphan diseases, there is an explosion. The budget has increased by 24.
Mhm.
And in those sectors, Europe is getting behind. So right now we are okay, but in the future they are worried. And one thing they say, and we could discuss about many things about the report, but one thing they say is, look, one problem we have is that too often we have in the EU 27 markets and not just one market.
Yeah.
And so we have EMA, we have some coordination in HTAs, but they are saying, look, we should create an EU HTA,
Mhm.
an EU agency for health technology assessment, knowing that price and reimbursement, since the budgets are national, is more complicated.
Yeah.
So one question I wanted to ask you was, since in a sense a health technology is a health technology, even though I understand that different populations have different health characteristics, and in different countries the alternative existing therapies may not be the same.
Mhm.
What would you think about an EU health technology assessment that would follow the principles you suggested, which is that it should be independent and free of conflict of interest and so on and so forth?
Yeah, I totally agree with Michelle about the sentence that it's important to prevent diseases. As a social epidemiologist, I think the how we can save more health expenditure is by avoiding that people get a disease. So I agree totally with that. I totally agree with that. And about an EU structure of health technology assessment beyond the one that will start in January with the clinical analysis, more related to the clinical assessment. Well, I think that it could be interesting because also, as you have mentioned, we have different markets, different government structure, different capacities to conduct this type of analysis. So having an European structure could help countries with less capacities or less expertise in that sense to improve their decisions about pricing and reimbursement. So, and I think that, well, although currently there is no EU structure to conduct health technology assessment in a comprehensive way, probably this could be a first step to have this kind of structure in the future, or maybe not, because the situations in the EU could change. But I think that with this regulation, we are moving to having this type of structure in the future. Maybe not now, but I think that the time will give us more reasons to push for having this type of structure at the EU level. And also related, because one interesting experience about the pandemic is this strategies to have joint procurement to purchase some vaccines, for example, against COVID. So I think that was an interesting experience, and one lesson that we have learned during the pandemic. And although we are not having more type of this instrument for other products, but I think in this type of situation, making this first step in terms of regulation, or in terms of having the experience of purchasing across the EU the COVID vaccines will help us and make us closer to having a new structure on health technology assessment, or having these joint procurement instruments for other type of product. And I think it's as you have mentioned, pharmas are globally, so we have to move to a more multi-country type of instruments, governance structure, or wherever. So I totally agree with you.
Okay, thank you. Yes, I mean, I agree in a sense that maybe even further, and we will also connect with what Michel was saying, that in a sense, after HTA comes indeed the purchases, and indeed and we argued that in a short paper with Michel and with Alain Fischer, the COVID vaccine joint procurement was a good example, and it could apply to this exploding budget of rare diseases, where indeed I think it would be important to and so it would be nice to have a European chain, EMA, EU, FTA, and then joint procurement. And you have to still discuss indeed how you manage to distribute, because, okay, the whole business is about indeed improving the trade-off between innovation and access.
Yeah.
You want both to keep the incentive for innovators, so that we have new products, and then you have to make them accessible. So, and in that sense, indeed, size matters. By the way, the US is not a good example. They have the biggest market, but at some point it was allowed, Medicare was prevented from bargaining on price, so they have the highest price in the world. And even though, of course, some pharma companies are happy about that, I think the US citizen taxpayer is getting a bad deal. And I think, but on the other hand, it is true that the more Europe we have, so the more we go towards a single market, the more attractive we will be.
Yeah, totally.
Thank you. Thank you.
Thank you.
We had a question from Antonio Estache, if you would like to ask it live.
Hear me?
Yes.
Okay. Hi, thanks a lot for the seminar. It's quite interesting. I learned a lot. But I do have some concerns, if you don't mind. Maybe it's food for thought for the future. The first one somehow has been hinted at by Matthias. I'm worried about access, and I'm just wondering, in the process of designing this regulation, who and how do you decide who is excluded? Because we do have a system right now in which we do know who is excluded. We have all these orphan diseases and things like this. And so this is part of the ethical process that needs to be built in these new regulation. It's always quite difficult. So my first question would be, how do you do that? How do you think about exclusions from the process? A related question has to do with implementation. It's also about implementation, but I'm thinking about Spain or Belgium, or countries where we do have strong regional differences. And in Spain, for instance, if you look at the way regions like Andalusia, who are now controlled by a conservative party, decide on the use of the access to technologies and things like this, and you compare them to other regions, I mean, how much of these differences can be built in? And how much should that drive, in a sense, the diagnostic that you're conducting? Because it drives access, it drives financing, it drives lots of decisions. And I know there's a lot of concern of coordination supranational at the EU level, but within countries you have major coordination efforts which make a big difference to the implementation. The effective access to health is very different across regions within a given country. So that would be my second question. Is that something that is fully internalized in the process of adopting these new regulation? And then I have a third question, which is more about finance, I guess. What's the cost of doing this thing? I mean, what part of if you normalize it to the cost of, the resources allocated to the sector, how much would you have to spend to do this supervision? What percentage of the total expenditures you have, or how does it compare to the current cost of regulation in the sector? Thanks a lot for the presentation, and sorry for the long set of questions.
Yeah, no problem. About the first question and the people of the groups or patient group that are excluded from the, not the decision, but that, for example, this system will decided to, or do not recommend to incorporate some drug. I think that it's very difficult when we talk about this type of decisions, really, when it comes to health. No, it's in a sense of an ethical debate. No, if I would be more simplistic, no, but when it comes to health, every amount of money is worth it. No, government should pay any amount of money for a drug that could save one life. No, usually the debate is put in these terms, but I think that we have to treat a population as an adult. Governments doesn't have all the resources that we want, so we have limited resources, and we have to maximize the health outcome of the population, given a certain amount of technology that we have to deliver to the population. When it comes to, for example, recently we have a debate here in Spain about new oncological drug for if I'm not mistaken, for breast cancer, metastatic breast cancer, that for three times the decision was to not finance this drug, and finally we have decided, not the government, but within the ministry there is like a department, not a department, like an organism or a commission that decide on financing and reimbursement, where there is some representative currently from the ministry, from the regions. So it's like a collective type of commission, and they finally decide to incorporate because the votes changed during this process, and finally the company gives some different information that convinced to incorporate. But I think that also there is some important issue here, that although health technology is not incorporated to the health system, there are some mechanisms for certain patients to give them a drug that is not financed by the national health system, but in certain conditions, if there is no alternative, we can incorporate and we can pay for this drug, although this drug is not financed and reimbursed by the national health system. So I think that if we are transparent with the methodology, transparent with the criteria, transparent with the decision, and explain this type of decisions to the population, it will reduce these, how these excluded groups will take the decision. Obviously, there will be some disappointment. That is not. It's normal, I think, when some group of patients have a health need and the government can find a solution to the medical need, there is some disappointment, and we have to deal with that. But if we increase our transparency, how we communicate the decision, how we explain this type of decision and methodology, I think it will reduce the probability of disappointment, although always there will be some kind of that. About the
Can you allow me to just follow up on this one? If you decide to go for EU version of this, right? A supranational version of this, there will have to be a coordination for the exclusion decision, and it may not be the same for different countries, and that's
exactly.
what I'm about.
Yeah,
and the same thing within Spain. Frankly, I mean, the decision, the efforts that different regions make to give access, in a sense, is quite heterogeneous also, and so that this sort of coordination issue is the one that worries me when I think about the implementation of the idea. The concept I like a lot, I can understand it, but implementation challenges are sometimes highly political.
Yeah, of course, and for the case in Spain, this health technology assessment system will operate at national level, and if this if the commission within the ministry that decide about financing and reimbursement approve the incorporation of a new health technology, all the regions must incorporate in the common portfolio of health services this health technology. They can moderate the access. That's true, but but we have a coordination. A coordination commission for the national health system, where the degree of agreement is really high, and I think that although some people see these differences between regions as a negative part of the national health system, I think that sometimes when one region decides to incorporate a new technology that other region doesn't have, in the time when we have more information about the implementation of the technology and the results in health terms, at the end, all the regions incorporate this new health technology. So having different regions that could have different decisions could be a negative part of the national health system, but also in other occasions, I think that regions learn from the others, and if one thing works in one region, at the end, it will be implemented at national level in this common portfolio of health services. So currently we have this common portfolio that should be implemented at national level, and with the complementary one that the regions can implement in their territories. I think it is an instrument to learn and to have this kind of natural experiments to see differences between countries and learn between regions, and that's a different part of this national regulation, that if within the ministry is decided to incorporate one health technology, all the regions should incorporate it. And if we have a debate about the effective access, as you mentioned, this should be addressed in this coordination system that we have when all the regions are represented and the ministry, and where we can debate how is implementing this common portfolio. And sometimes if we, as I mentioned before, if we are transparent in not only about the decision, but only about the implementation of some things, the comparison between regions could affect politically how the government is seen by the population. So sometimes the transparency helps us to harmonize and to have a more cohesive implementation of health technology that we are talking now, but also with other issues about the national health system. And you have made another question.
Sorry to interrupt. I think probably move to Michelle's question, because it's almost 2 o'clock.
Okay, perfect.
Sorry about that.
Bye-bye.
Sorry.
No, I had just a comment coming back to what Antonio said about, access and the ethical aspect of the access. And we should not forget that the companies there can make tough decisions. And for example, during the COVID, they decide not to develop an antibody across Europe, but to propose this antibody. It was mainly in Asian countries, actually. And the Asian market becomes more and more important for companies. So we talk about EU and the US, but we should not forget the Asian market and the fact that companies can make decisions about indeed access, as well as regulatory agencies and HTA agencies.
Yeah, totally.
Sorry?
No, I agree with you that we have to keep in mind this global market or global field work and these rules. I think that one issue I commented before is that we're trying to move these signals that we send to the companies in Spain to trying to have a more demand-oriented market from this offer market that we have right now. So the companies offer their products, and we can decide or have a decision of about which type of products they produce. But I think if we move the incentives and we create incentives in the demand side, maybe we can move a little bit. It's very difficult, and I'm idealistic maybe, but we can maybe move towards a more market oriented to the needs. And I think in terms of international cooperation, I think that we have to move to this type of cooperation between countries, not only in the EU, but at the international level, to avoid this type of situation. So to avoid these strategies of the pharma industry.
You are fully right, and this question of incentives for all stakeholders is critical. Thank you very much again for your seminar, which was really excellent.
Thank you very much.
Indeed. Thanks a lot.
Thank you.
Bye-bye. Thank you.
Goodbye.
Bye-bye.